Welcome to Season 4 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former Commissioner of Health in Baltimore City. Our goal is to bring scientific evidence and experience to current topics in public health through engaging interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, it's time to catch up on some of the latest evidence from researchers with the Novel Coronavirus Research Compendium, available online at ncrc.jhsph.edu. First, Dr. Nick Wada tells me about a study led by researchers in Bangladesh and the United States, which assessed whether masks really reduce the spread of COVID. Then we turn to schools. Dr. Kate Grabowski discusses a Lancet paper from the United Kingdom about what happens after a child in school tests positive for COVID. Should schools send all the close contacts home? Or should they adopt a test-to-stay protocol, giving daily tests and allowing kids to keep coming to class if negative? Let's listen. Dr. Wada, how are you doing? I hear we're going to talk about masks.
We are, yeah. Thanks for having me back, Josh.
So tell me about this study. I think I've been reading about it a little bit in the paper.
Yeah, so really high-quality evidence on the effectiveness of masks in controlling transmission of SARS-CoV-2 has been really hard to come by. And one of the reasons we've heard about this in the news is because this is really one of the best large-scale trials of mask wearing that's been done.
So is it true that they actually randomize people to wearing masks?
So this is actually a cluster randomized trial, meaning that people were randomized to mask use or non-mask use. Rather, this was randomized at the village level. So this was a large-scale cluster randomized trial of community-level promotion of mask wearing in Bangladesh that took place over approximately 8 weeks from the end of fall 2020 to April 2021.
So if I were living in one of these villages and I was in the mask group, what would happen?
So if you were in the mask group, you would first be assigned masks, or masks would be distributed in your household initially at the start of the study. Masks would be available to you in distribution several days a week in public places, in the market or in sort of the town square. And masks would be available to you at your mosque as well.
But I wouldn't actually have to wear the mask. Is that right?
No, it would still be up to you whether or not you wanted to wear the mask or not. And as you strolled, going about your daily business through the market, you might encounter somebody assigned to your village in a public spot who would be encouraging people walking by who weren't wearing masks to do so. And you might also see speeches once in a while from local community leaders urging you to wear a mask. So this was really a multi-pronged trial.
Got it. So if I'm in one of the villages that's randomized to mask wearing, I get masks, I get encouraged to wear masks. I'm not forced to wear masks, but I might well be more likely to wear masks. What would happen if I were in a village that was not randomized to mask wearing?
Nothing. So there was no intervention for the control villages.
Got it. And so the researchers then got a chance to compare the differences in COVID between the villages that were randomized to mask availability, really, and the others that were randomized to same as usual.
Right. So they were really interested in two things. So they were interested, first of all, whether or not their intervention worked in terms of encouraging people to wear masks. So they had people, enumerators, standing 24/7 in public spaces, watching and counting how many people wore masks. And a secondary outcome they were worried about was whether masks would encourage people to walk more closely together or to behave with less social distancing. So they were attempting to measure the degree of social distancing or physical distancing in public places, as well as mask use. And then they followed up with households via telephone surveys and measured how many people had experienced COVID-19 symptoms. And if people were symptomatic during the study period, they were asked to submit blood for antibody testing. And so the primary outcome of this study was what they called symptomatic seroprevalence. In other words, evidence that somebody had had COVID-19 with confirmation via an antibody test.
Got it. So let me ask the first question. Did making masks available and giving education on masks actually increase mask wearing?
It really did. And it started from a very low base. So control villages, in other words, villages where no intervention was attempted, had only 13% mask use that was observed. And that tripled in intervention villages, up to 42%. So even though it wasn't universal masking, it certainly seemed to have made a difference.
Got it. And then the big question is, did that big increase in masking actually reduce the chance of people getting sick from COVID?
So it seems that way. The intervention villages that were masked or where masks were promoted, had approximately 10% less symptomatic seroprevalence than the control arms, which doesn't sound like a whole lot, but is actually fairly considerable considering that only 42% of people were wearing masks. And it worked out to thousands of extra cases in the control arms. Now, there are issues with that outcome measurement that lead a skeptical reader to be a little bit wary of assessing these effect estimates with any precision. For one thing, they never assessed baseline seroprevalence, so they didn't check people's levels of antibodies in these villages before they did the intervention. So some of these cases, some of these people who reported symptoms and were seroprevalent may have already had COVID-19 and simply gotten a cold during the trial. So we can't be 100% certain that this reflects a real 10% difference in COVID-19 incidence or prevalence, but it strongly suggests there may have been an effect.
Got it. Now, did they study different types of masks?
They did. There were actually a handful of cross-randomizations or sub-experiments that were conducted in the mask villages, and one of them was cloth versus surgical masks. And they did have some evidence that surgical masks were more effective than cloth masks.
So I've seen some criticism in the media where people say, oh, there's hardly any difference from mask wearing. Do you conclude that from this study? Or what do you think the bottom line is for people who maybe aren't living at the moment in a village in Bangladesh that was in this study?
Yeah, well, so it's important to stress that this doesn't measure individual effectiveness in preventing either transmission from somebody who's infected or protection against somebody who's infected. But what it does measure is whether or not this overall intervention of promotion of mask wearing reduces the overall level of transmission in the community. And I think this is pretty good evidence that it does. Despite the apparently small effect estimate, that's 10, if you can find an intervention that reduces transmission by 10%, and it's as low cost as this one, I think it's a home run.
Got it. And so what's your bottom line for, say, the United States?
Well, it's hard to know how this would translate necessarily to the United States. This is it's a very different setting, and sort of the cultural discourse surrounding mask use is different than it is in Bangladesh. So it's hard to say, but I think there's been a general neglect of rigorous study of non-pharmaceutical interventions in low and middle income countries, and I think this is a good role model for conducting trials like that. And it's really an encouraging proof of concept that could be at least conceivably exported to other settings that are somewhat similar to Bangladesh.
Got it. All right. I won't ask to read too much into one study. I appreciate your caution, but also appreciate your clear explanation. Thanks so much.
Thanks a lot.
Dr. Kate Grabowski, thank you so much for coming back to Public Health on Call. I know you're one of the leaders of the Novel Coronavirus Research Compendium, and you're going to talk about a study that is very relevant to a lot of parents and kids these days. What was the topic of this study?
So the topic of this study is using rapid tests to control SARS-CoV-2 transmission in schools, and whether or not that's better than quarantining of students when they come into contact with COVID cases.
Got it. So to make sure I understand, someone in the classroom is sick. Option A is to send everybody home. Option B is to keep testing all the other kids, but keep them in school. How does option B work?
So option B would be to test the contacts of the case for a period of 7 days with a rapid test each day. And they would come into school, a school nurse would test them each day for over a 7-day period, excluding weekends. And if they were negative, they could stay in school.
So option A, with quarantine, all the kids go home. They're not in school. Option B, sounds like what some people call test to stay. The kids get to test, and as long as they're negative, they can keep coming to class.
That's exactly right.
So what did the researchers do to compare these options?
So they actually did a randomized trial. It was a cluster randomized trial implemented at the school level, where some schools were randomized to option B in this case, which was the test to stay. And then the other schools, the control schools, were randomized to the standard of care, which was just quarantine. So for 10 days.
So if I had my kids in the schools that were quarantined, someone gets sick in class, the whole class or whoever was near that child is going to be sent home for a while.
Yeah, it was close contacts of the case. And who was close generally was you had to be within 3 meters of that child for at least 15 minutes.
Got it. And then yet the other schools, they got a lot of tests and maybe they got to stay in class. So what happened when they compared the schools with these different approaches?
So there were two primary outcomes in this study. And the two primary outcomes first were COVID-19 related absences, school-related absences. And then the second outcome was transmission within schools. And that was measured as the symptomatic rate of COVID within those schools.
Well, let's talk about the first one. In terms of the absences, what did they find?
So this is a little tricky. So in terms of the absences, they found that there were 20% fewer absences in the test to stay arm, but the results were not statistically significantly different. So they did see a trend towards lower rates of absences in the intervention arm, but they couldn't say for certain whether or not it was different than the control arm.
I see. So you might imagine that it would be different because with the quarantine arm, they would be quarantining a whole bunch of close contacts, perhaps. Whereas the test to stay, the goal is to keep the kids in school. There was a signal for that, but it wasn't a huge finding of this study.
Yeah, and I was actually pretty surprised that there weren't fewer absences. I think that partly had to do with the fact that compliance with the rapid test was actually quite low. And so the authors did another statistical analysis where they adjusted for compliance, and they did see there were even fewer school absences in the testing arm, the test to stay arm, when they did this adjustment.
I'm not sure what you mean by compliance with testing. Could you explain that a little more?
Yeah, so we actually looked at the student contacts who were assigned to do the daily rapid testing. Only 42% of those daily contacts actually complied with the testing, which is pretty low. And there were a few reasons for that. A large proportion of those students simply refused to do the contact testing. Some could not be available or located for the testing, either because they were missing school for some other reason, or also it says because they refused. So it looks like there were some refusals in the I don't know category. And then there were some instances where the whole class was shut down for outbreaks, which were deemed unrelated to the intervention, but there was a rise in the Delta variant during this time period, and sometimes whole classes had to be shut down. And so they couldn't implement the daily rapid testing in those classes. So that affected the compliance as well.
I see. And if somebody was refusing the daily rapid testing, they would get sent home, right? They wouldn't get to just stay in class.
Exactly. They would get sent home.
So that's one reason why perhaps there wasn't that much of a difference between the two groups.
Exactly. It's probably one of the big reasons.
So we have a situation where there are fewer kids being sent home in the schools with the test to stay protocol, but not as many as we might have thought. What happened to the transmission of the virus?
There was no difference in transmission of the virus between the two arms, which was also which is a good thing. But yeah, we didn't see a reduction of transmission due to the intervention, but we also didn't see an increase in transmission. And there was a lot of concern at the beginning of the study. And one of the reasons for doing this study was because people were concerned that with using rapid tests, which are less sensitive than PCR, that you might see an increase in transmission. And so one of the big findings here is that, in fact, this intervention is what we call non-inferior to the quarantine, meaning that there are no differences in transmission rates between the two arms.
So they managed to have fewer absences, albeit not statistically significant, without evidence of greater transmission.
Yes.
Now, how robust is that finding? Like, how confident are you that there's not greater transmission, and maybe because of, all these other issues with the study, et cetera, that they just didn't see it here?
I actually feel pretty confident that there weren't big differences in transmission. I think one of the more interesting findings in the study actually is how few contacts actually went on to test positive for SARS-CoV-2. So if you looked at all the contacts in either the intervention or the control arm of people who tested positive for SARS-CoV-2, only 2% of those contacts actually went on to test positive themselves at a later point in time. And so overall, there were really, really just low levels of transmission within the schools themselves. And the nice thing about the UK is that they're able to link data across their healthcare systems. And I think if there was a signal here, they would have seen it. So I felt pretty good about the results.
So bottom line, do you think parents should be more or less comfortable if their school system adopts test to stay?
I think even the authors weren't necessarily convinced by test to stay. In the discussion section, they argue themselves that there needs to be a discussion about this with parents and with schools. There's, these interventions aren't cost free. You need the staff to be able to implement them. And so whether or not compliance can be achieved in schools might help reduce school absences in the future. And another interesting facet about this study is that compliance with the testing varied dramatically across schools. So it was, anywhere from less than 5% to more than 80% compliance within schools. So maybe there are some schools where this might work and help reduce a lot of COVID-19 related absences, but maybe there are some schools where it wouldn't work. So I think, after a read on this study, I think the jury is really still out on test to stay. And I think that there may be some settings where it would work really well. And I think we need to study it a little bit more.
Great. I know that sometimes these studies defy simple conclusions. I appreciate that nuance.
Yeah, this was a complicated one for sure.
Well, thanks so much for coming to explain it today.
No problem. Great to be here. Thanks for having me.
Public Health on Call is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Spencer Greer, Niall Owen McCusker, and Matthew Martin with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media support from Grace Holes Fernandez and Caroline Wong. Thank you for listening.